on Zoom, so I can't see. Let me know if you can't hear me. So this talk is going to, as Dr. Rockwell mentioned, focus on global health challenges, particularly as it relates to neurosurgery. I need to get rid of that.
You clicked on got it?
It's not on. It's not on here. I'll keep going. But as I was making this talk, I realized that I'm going to be pretty good at defining this problem, but I don't have a lot of great solutions. So show you what we have, and just okay, just some introduction to global health and global surgery in general, not neurosurgery yet. Some staggering numbers is that 5 billion people lack access globally to just basic, safe, affordable surgical care. And there are 140 plus million necessary surgery procedures that remain undone worldwide. And this comes out of a very well-known paper in Lancet that came out 10 years ago that I'm going to reference a few times throughout this talk. Global neurosurgery over the last few years has become a central part of these initiatives to try to address the unmet burden. Early global neurosurgery efforts focus primarily on surgical missions to provide care. I know that there's a lot of controversy over surgical missions. I personally am not here to judge, and I'm going to remain neutral, but I will say throughout this talk a couple times that there is some concern over the ethics and sustainability of these surgical missions. Now, global neurosurgery, which is still in its infancy, has pivoted to the things that you see up there: training local personnel, collaboration, bolstering care systems, and acquiring resources. But the problem is we don't have any metrics for how we're doing. So it's hard to evaluate our progress. And we've just now developed some metrics over the last couple of years that I'll share with you. So in terms of global neurosurgery, 22 million patients annually around the world just require some type of neurosurgical consultation. This is not cases, this is just consults. Almost 14 million of those patients are going to require some type of neurosurgery. Worldwide, roughly from my research, there's about 50,000 neurosurgeons, but we're very concentrated in high-income countries, even though 80% of neurosurgical cases are going to arise in these lower and middle-income countries. So that leaves us with a deficit of 5 million neurosurgery cases a year that go unmet. Ideally, you want a ratio of 1 neurosurgeon per 100,000 people. The minimum acceptable ratio is 1 to 200,000, and you're going to see in a second that we are far away from that in many places around the world. Sorry, there's a delay on this. So in terms of distribution of neurosurgeons worldwide, China and Japan alone somehow have 18,000. That was shocking to me when I was doing this talk. And the US and Canada, roughly 5,300. Europe has another 10,000. Problem is, you go to some place like Africa, almost 500 neurosurgeons for almost 1 billion people, which is a huge gap in care. And there are 18 countries, at least, probably more, that don't have a neurosurgeon at all. If you look at pediatric neurosurgery, it's actually even worse. 85% of the roughly 2,300 pediatric neurosurgeons are concentrated in higher income countries. So this graph basically says, sorry, that's a little bit blurry up there, but it basically says in graph form what I just said is that blue and green, as you move into these higher income countries, you see a higher concentration of neurosurgeons, and then the red on the left, you'll see there are some countries that have maybe 1 or 2 for an entire country, or even none at all. So it's a huge problem worldwide. And when you think about global neurosurgery, there's really 10 conditions, in my opinion, and also in my research, that form the foundation of neurosurgical care. TBI, stroke, and hydrocephalus are going to be the 3 biggest. The other one is brain tumors. Spine tumors, there's a deficit also, of course, but they're just much more rare. Spinal cord injuries, neural tube defects. We do see some of that here in the United States, but a much bigger problem worldwide. And then things like ruptured aneurysms, AVMs, infections, and seizures are big, are sort of the remaining conditions that would form kind of the foundation of a neurosurgery residency. So as I mentioned, TBI, stroke, hydrocephalus, and brain tumors are going to make up the vast majority of global neurosurgery needs. And there are some places around the world where some type of CSF diversion procedure, whether that's a shunt or something called a third ventriculostomy to try to avoid a shunt, makes up almost half of all the procedures that are done. In terms of TBI, by 2030, it's going to be the third leading cause of death worldwide. Most of those are caused by traffic accidents. And interestingly, in 2017, there was a booklet that came out called the Disease Control Priorities. This is the third edition of it. As far as I can tell, that is the most recent edition. And they identified 44 surgical procedures that would help inform global health spending priorities. Only 2 of them on that list were neurosurgery related. It was burr holes and craniotomy for TBI and shunt for hydrocephalus. So we're getting better, but I think we obviously need more neurosurgery procedures on there as priorities, specifically things like for epilepsy, for brain tumors, infection. So this is a very busy chart, but I'm going to walk you through it. This is on the top by WHO region annual cases broken down by neurosurgical illness per year. And it's broken down by region also. So just what I want to show you is the burden. So AFR on the top left there, I don't have a pointer, sorry, is traumatic brain injuries. That's the Africa region, far and away the biggest issue worldwide, followed closely by stroke. And then you can see the burden of HC up there is hydrocephalus. Go down to a different region of the world. So SEER is Southeast Asia. You can see the burden of TBI there. You can also see the burden of stroke. If you look at the US, TBI is obviously a big problem here also. But what was striking to me was that 1250 NTD is neural tube defects. So again, do we see it here in the US? Absolutely. I did a fair amount of it at Primary Children's as a resident because it's a big referral center. It's a much smaller problem here in the US than it is worldwide. And then again, on the bottom, that's globally, all of these regions put together, cases. And you can see again, next time I'll bring a pointer, but your biggest issues are going to be TBI, stroke, and hydrocephalus. So, oops, go back. This is neurosurgeons per capita worldwide. The redder you are on this map, the less neurosurgeons you have. And, you can see that Africa stands out there. There are many countries on that graph that don't have a neurosurgeon at all for almost 1 billion people. And then this is consults per neurosurgeon. So not cases, just consults. And so as you get more red, you can see, again, focusing on, Africa, Southeast Asia, you might have for one neurosurgeon more than 10,000 consults, which is just absolutely insurmountable. And I'm going to pivot for 1 sec here. Let's see if this arrow shows up to point out that very small country right there. And that is Burkina Faso, West Africa, which is near and dear to my heart because I lived there for 2 years a long time ago as a Peace Corps volunteer when I was a bit of a lost soul and didn't know what I wanted to do with my life. So Burkina Faso is a landlocked country, roughly 23 million people. The capital city is difficult to pronounce. We called it Ouaga for short. Most of the population there exists on subsistence farming, but it's actually the 4th largest gold producer in Africa. There was a gold mine actually in the village where I lived. It's really dangerous work. There's no OSHA oversight of these places. So extremely dangerous. It is one of the world's poorer countries. And unfortunately, it has been negatively impacted by terrorism. When I was there, again, this was a long time ago, it was a very peaceful country. It's now no longer a Peace Corps site, unfortunately. And I read in 2023 that Burkina Faso per person accounted for 25% of all terrorism deaths worldwide. So very sad to see it devolve like that. What did I do when I was there? So I was a health volunteer. So I kind of thought I was going to go into med school. I wasn't sure. I was assigned to a local village clinic in a rural area. There were no physicians. It was staffed by 2 nurses. The official language is French, and then there were multiple dialects. No electricity. We had 1 solar panel. We used to power a fridge to keep the vaccines cold, no running water. And it really was amazing to see what these providers did with such little resources. So a lot of it focused on prenatal care and baby deliveries, education on contraception, some basic wound care, and then vaccination. So what we would do is we would take the vaccines out of the fridge in the morning, get on bicycles, bike around to the surrounding villages and vaccinate all the kids, and then come back at the end of the day. So I used to be in really good shape when I was doing that. It's falling off a cliff here, but these are some pictures. These are actually taken from a camera I haven't taken a picture with anything but an iPhone in over 10 years. So these are probably blurry because I had to put them out and then take pictures of them and post them. But that is, sorry, there's this delay. That is the house where I lived, and that was me when I was considerably younger. And then that's the bathroom. That was all we had. And then that is the clinic where I worked. And on Mondays and Tuesdays were the women's prenatal care days. So there would just be women lined up. It was the only clinic for about 50 miles around. And so there would be women just parked outside there waiting all day to get like folic acid pills, get their abdomens measured, things like that. So that is what sparked my interest in global health. I didn't know I wanted to do neurosurgery back then, but just by way of background. So just to pivot back now to global neurosurgery, we are behind on addressing this unmet need, but as you can see, we're at least starting to get a little bit better. So if you look at the publications on global neurosurgery, as you move from the early 2000s to now, we're starting to recognize this unmet need. And there is precedent for global neurosurgery. It's a busy slide, but all I just want to point out here is that as early as the 1890s, Harvey Cushing, who many of us consider one of the founders of modern neurosurgery, was traveling around to Europe, exchanging ideas on taking out brain tumors and hydrocephalus and things like that. And it just mirrors these early initiatives in global health. And then all the way on the top right there, that WHA resolutions, I'm going to talk about that specifically in just a couple minutes. But really, it's just recognition that there's an issue. So this Lancet report that came out in 2015 on global surgery, not neurosurgery in particular. Prior to that, really any discourse on surgical care in these lower and middle income countries had been lacking. And so they specifically said surgical services are the neglected stepchild of global health. And we have to do a better job of meeting this need and closing this gap in care. The problem is 9 out of 10 patients in these countries can't access surgical care, and the estimated deficit of neurosurgeons is 23,000, which is a lot, especially when you think about the length of training, 7 years here in the US, 5-6 years in other countries. So that's not anything that's going to be closed quickly. I already sort of talked about the numbers on the left, but just so you can see the financial impact around the world of lost productivity, $21 trillion in patients who can't work, can't provide for their families because and again, this isn't neurosurgery specific, but just because they can't get a basic surgery that they need. And there's what we need to invest, not we, just the US, but globally, to try to close that gap. So what are the priorities in neurosurgery? So WHA, World Health Assembly, is the decision-making body of the WHO. And in 2022, they had their 75th anniversary meeting, which is why it's WHA 75. And they laid out several priorities that they were going to focus on. Here's a few of them. One, folic acid fortification. Again, here in the US, it was mandated that it had to be in our cereal grains in the late 90s. Globally, less than 100 countries have implemented this. And then they came up with this IGAP, which was to address the global burden of epilepsy. So I'll show you in a second, is very high. And it ties into the other neurosurgical issues. So who has seizures? Patients that have brain injuries, hydrocephalus, brain tumors, et cetera. And then they came up with these priorities to achieve their agenda, which I'll talk about. But just to show you, here's that busy graph again, but just to highlight, that's epilepsy. And then HIC, high income countries, LIMC is low and middle income countries. So you can see there's a huge burden worldwide of epilepsy as well. And so the WHA, wait for it here. So this table is just to show you that they've been passing initiatives since the year 2000, but now they're focusing more on specifically defining the priorities. So I talked about spina bifida, talked about TBI, stroke, epilepsy, and tumors. It's going to become a theme over and over. And then they came up with these examples of prevention. And I thought this was interesting because when you think about global neurosurgery, you think about, well, we need to train people to do the cases. But I think it's important not to overlook that advocacy and prevention is also something that we as surgeons can do. So this paper just came out a couple of years ago. It's out of one of our pediatric neurosurgery journals. And these authors who are interested in global health said, yes, neurosurgery focuses mostly on surgery, but Prevention is a different way of caring for our patients that we shouldn't ignore. So if you look at the global prevalence of spina bifida, it's 1 in 1,000. It's much lower in the US. If someone has a neural tube defect, chances are they're going to require neurosurgical consultation. And many of these cases are preventable through just simple folic acid intake. I know that the specific dose is at least 4,000 micrograms a day because I used to hand out those pills in Burkina Faso twice a week for 2 years. And so we as neurosurgeons, these authors say, yes, we need to do the surgeries, but we also need to be advocates for prevention. And if someone comes in with a child with a neural tube defect, we should be counseling the parents to maybe help prevent that in a future pregnancy. And we should also be educating our own colleagues and ourselves regarding the role of folic acid in spina bifida. So just one example of how it's not just a surgical problem, it's also advocacy and prevention. So getting back to these strategies to address global neurosurgery needs, I'll talk about each one of these briefly. So the surgical camps and missions, I know these are controversial, so let's go through it quickly. This can be through an individual or through an institution or through an organization. And they go to a country where there's a need and they provide these surgical services for a short period of time. There's dozens of examples of this in neurosurgery. That's just 2. The one in Ukraine, the co-pilot project, is more of an adult neurosurgery camp, and then Project Shunt in Guatemala focuses on pediatric hydrocephalus. Again, there's controversy. What's the sustainability of this? Is there secondary gain, maybe in the past, in the people going and promoting a political or religious ideology? And I think it's important to note also that if you're going to go and do this, you shouldn't assume to know the needs of the local providers. There's one really well-known example in our field of someone who went to the Amazon to provide neurosurgical care, and they brought gauze and syringes, and they were the provider was like, oh, thank you, but didn't look very thrilled. And they were like, well, what do you need? And he said, well, I need canoes. And they need canoes because they couldn't get the patients that needed help to the hospital. So I think it's important not to just assume to know what someone needs. So obviously education and training are going to be huge in closing this gap. So, not only transferring skills, but transferring knowledge, providing educational materials, and focusing on the next generation, getting students that are interested to come over to these programs and see this firsthand. The problem is there are many countries that don't have a neurosurgery residency training program. I'm sure that's true for global surgery in general. And it's important to know that education, it's hard to take, it's hard to get an education if you're in a politically unstable area. So that slide I showed you a few minutes ago where there's no neurosurgeon in Sierra Leone, that country was in civil war until just recently. So, the other issue that plays into this is cost. So in the US, we get paid to be residents, not a lot, but it's a living wage. In other countries around the world, you pay to be a resident. And if you don't have a training program in your country, then you have to pay to travel to the nearest country that does and pay for your housing. So that can just be cost prohibitive for many people. The other issue is neurosurgery residency is not standardized. The training is not standardized worldwide. So here it's 7 years and you can do a fellowship if you want to. But worldwide, it seemed to me when I was making this talk that it's just all over the map. And one of the best ways to get data on global health needs is surveys. So here's one that was sent out to almost 200 people, neurosurgery trainees, recent graduates. The vast majority were from these lower and middle income countries. The majority were male, as is most of neurosurgery. And over a quarter of them were required to pay for their own training. Half did not have a training program in their home country. And the length of training was all over the place, as little as 1 year, as long as 10 years. I have to assume that 10 years includes some type of medical school education as well. And then they asked about work hours, and it was kind of all over the place. 40% said they work more than 80 hours a week. And then there were people on the other end who said, well, I work, 10 hours a week. So it's difficult when the training is sort of all over the map. But really in researching this talk, it seems that training more neurosurgeons is the best solution to help close the gap. The issue is a lot of these residents that leave their home country to get training, they may not always go back. They may have better opportunities in the country where they are. So we need to prioritize the training to students from countries that lack these programs. The best way to do it would be by developing new in-country training programs. When I was a resident, our chairman flew back and forth to Kuwait several times, to Kuwait City, and helped set up a neurosurgery residency there. So it is possible, it's difficult. You can also do visiting residencies or fellowships. We've had many international fellows in our department, and I'm sure in other departments here. And there are foundations in neurosurgery to help sort of offset some of these costs. So going hand in hand with that is health policy. So if you're going to provide any type of surgical care, including neurosurgery, you need a decently functioning health system. And it has to not just be the surgery, it has to be, you know, from pre-hospital, are they healthy enough for surgery, through the surgery itself, and the follow-up. One of the best examples of that is a shunt. You know, I think that placing a new shunt is a straightforward neurosurgery procedure, but data on shunts is that 50% of them will need to be revised in a year, and there can be up to a 10% infection rate with them, which is, as many of you know, the bane of our existence. But you know, if you go and you place a shunt, who's going to do the follow-up? Who's going to revise it? So what we're trying to do now is establish databases to get this, you know, for epidemiology and statistics, and to develop these metrics that I mentioned earlier. You know, we need to show that there's a need if we're going to advocate for funding. And again, one of the best ways to do that is through these surveys. I have a few more coming up. And our professional societies have started to step up more recently and take an interest in this. So the WFNS has actually been around for quite a while, but it's the best example of this. They represent 130 different societies of neurosurgery around the world. They focus on education and surgeon training as opposed to these surgical mission trips. They have free web-based educational platforms that are accessible to all members. In 2021, they initiated this program called Africa 100. And their goal was to train 100 neurosurgeons that would stay in their home countries to practice. There's also a training center in Morocco funded by the WFNS. It's a neurosurgery residency program, and there's very strict application criteria. And one of them is you have to be a citizen of a country where there's less than one neurosurgeon per 1 million people, which, as you saw earlier, is a lot of Africa and Southeast Asia. And there's also international neurosurgery education opportunities through some of our other professional organizations. So again, all this training and education, we're 23,000 neurosurgeons short, or a 7-year residency. So what do you do in the meantime? So one thing that I found that was very interesting was this idea of task shifting or sharing, which probably exists in other surgical specialties, but in terms of neurosurgery, you know, this is the idea of delegating neurosurgery procedures or sharing them. The technical definition is to less specialized or qualified practitioners. You see, I put up there that I disagree with this definition, and I think that, you know, a general surgeon in one of these underserved countries would be very qualified to do an emergency trauma neurosurgery procedure. The issue with this is that we don't have a lot of clinical outcome data on it. What do we have? We have surveys, like I've mentioned. So here's one that I found. This looked at 47 low and middle income countries who provide some type of neurosurgical care. They got over 100 responses. And you can see who's responding here. Mostly attending neurosurgeons, but then residents. There's some general surgeons, some general practitioners, and even some people who are not physicians at all that may be doing these procedures. And one of the issues with task shifting or sharing, it's not always endorsed by a specific country's health ministry. And there's not a lot of standardization for it. So the duration of training, you know, if you're going to train a general surgeon or a nurse or whoever to do burr holes or a shunt, it could be anywhere from, well, I got no training based on the responses to maybe I got a month to actually I did a 2 to 3 year program. And as you can imagine, many of these, most of them, in fact, are life-saving trauma surgeries where to get to the nearest neurosurgeon would either take too long or it's just impossible. So here's where the survey respondents were located. Again, no surprise. And then here were the procedures performed. And you can see at the top, burr holes, craniotomy for hematoma, EVD, external ventricular drain, and shunt were far and away the majority of procedures performed. I would consider all of those life-saving. But then as you go down the list, there were actually you know, people doing aneurysm clippings and spinal fusions. That would probably be more the task sharing where you're doing it with a neurosurgeon, because those can be very complicated. And then they looked at it and they said, well, who's doing what based on complexity? So on the bottom there, you see complex, basic, and emergency. And if you look at emergency, the blue graph, most of these are being done by specialist neurosurgeons. But then if you look at yellow and black, it's neurosurgeons without board certification and general surgeons. And then again, some people who are not even physicians. So the issue with this is, how did these patients do? Well, we don't really know. We have some single center stuff, some opinion. Well, I did burr holes and the patient left the hospital, but we don't have great metrics on it. I would say that task sharing would be preferable to task shifting, so that whenever possible, if there's a neurosurgeon there that can do it in conjunction with another physician. But this is one way to just increase capacity while these training programs are expanded. If you talk to some of my colleagues, they're going to criticize this and say, well, this is our specialty and I did a 7-year residency and this should be our domain. And I would argue that that's entirely unreasonable in countries where there isn't a neurosurgeon. There is agreement in our professional societies that this should come with some type of standardization, some type of maintenance of certification, that it should be endorsed by local governing bodies, and that it maybe should be for emergency procedures only. But then what do you define as as an emergency procedure? Obviously, like an epidural would be an emergency, but can someone with hydrocephalus wait a day to get to a neurosurgeon, or can they not? I think that would be pretty subjective. So I thought this was a very interesting way to help close the gap while we're trying to, increase the number of neurosurgeons worldwide. But really, what's the way forward is just collaboration. This is a simple, just a lollipop chart showing the higher income countries in yellow and the number of collaborations with the lower and middle income countries in blue. And they are somewhat concentrated at this point in global neurosurgery. So Uganda has, multiple collaborations, which is not only a good thing, that can lead to competing interests. And there are many countries that are not on this list on the left-hand side that really need to be. So I would say that these collaborations don't necessarily always lead to improvement. And that, again, we don't have a lot of literature evaluating how effective these are. One of the reasons we don't is that we can't agree upon what we're measuring. So how do we advocate for funding? Is it number of neurosurgeons per country? Is it number of procedures needed? Is it what they have available if they have a drill or something? Is it outcomes? Until we agree on that, I think we're still going to struggle. So in 2015, again, I mentioned that a lot of the literature on these international neurosurgery collaborations are not very robust. But in 2015, for global surgery, not neurosurgery, but global surgery, there was this criteria called the fairness criteria that was created to help try to standardize and assess the effectiveness of these partnerships. It's really involved, so I just have one slide on it coming up. But it basically divides these indicators for success into short, medium, and long term, and then categorizes them as inputs and outputs. And I'll show you that in a second. It's not validated in neurosurgery yet. But in 2022, a group of neurosurgeons came up with a modified fairness criteria to try to help better define specifically the impact of global neurosurgery. Unfortunately, there's no current global neurosurgery collaboration that fulfilled all aspects of the criteria, which is understandable. And there was not great inter-rater reliability, but this is just one kind of example of it. So this is the short term, the original fairness criteria developed for global surgery, the modified fairness criteria that were developed for global neurosurgery. And you can see the inputs are like, well, did we coordinate well beforehand? Did we have enough resources? And then you go down to the output, and it's, well, number of procedures. Did we bring publicity to the local hospital to try to generate interest? Did we maintain cultural appropriateness, things like that? So again, very involved, but that just came out in 2022. So we're really early on into just evaluating how well we're doing. And so, when you think about global neurosurgery and the deficit of neurosurgeons, you have to think about women in the neurosurgery workforce, which are, we're typically, traditionally, I should say, underrepresented. So again, survey data, over 200 countries. If you look at the US, roughly, as of a few years ago, roughly 12% of neurosurgeons in the US are women. Of these 210 countries that were surveyed, 92 had no female neurosurgeon at all. again, the majority of the respondents were these low middle income countries. The country with the highest percentage of female neurosurgeons was Curacao, because they had one, and it was a woman. And that was a few years ago, so I don't even know if that's still true. But actually the highest overall percentage by region was Africa, which is shocking because there's so few neurosurgeons there in general. But they actually have a higher percentage of women than we do in the US and Canada, even though they're the smallest workforce. So you can see here the deficit, the green, this is by WHO region. The green is male neurosurgeons, the pinkish color is women. And why do I bring that up? Obviously personal reasons, but the big reason is that if we're going to close this gap, we have to attract both men and women into the field. And it's important to note that a higher resource setting doesn't necessarily imply decreased barriers to a neurosurgical career. There's, been some research done that shows that female surgeons in general will face a higher expectation for childcare. They have disproportionate career opportunities. I think I personally have been very lucky and felt very supported thus far, but worldwide, if we're going to close this gap, we have to attract both male and female medical students to go into our specialty. And the best way to do that, the research shows, is mentorship. So women that have female mentors are more likely to go into the field. And just going to close here with just some of the stuff that we're doing here at the U. In the middle there is my colleague, Carol Budahowski, who has gone over to Tanzania a couple times now. And I'll talk about that in just a minute, but he gave me these pictures, and you can see that's the drill that they're using to do burr holes. It's probably some Home Depot or Black & Decker drill, but again, they're doing the best they can under the circumstances. So his work is called the Tanzania Stroke Project. Again, stroke is a huge issue in neurosurgery worldwide. Someone around the world, someone has a stroke at once every 3 seconds. The burden is disproportionate on the lower and middle income countries. And so what do you need when you have a stroke? You need a lot of people need something called a mechanical thrombectomy. I don't want to go into the technical details of it, but there's some criteria for who gets it. But what it is someone with what's called an LVO, or a large vessel occlusion, so a clot in like the carotid artery, middle cerebral artery, etc. Can they get somewhere where one of our interventional neurosurgeons can pull that clot out? So there's just a map showing where Tanzania is located in East Africa. And then if you look worldwide at the access to thrombectomy, there we go. Sorry if it pops up. So the red there all over the world is countries where less than 10% of the population would have access to thrombectomy if they had a stroke with a clot. And then anything in gray there means there's not even enough data to collect it. So again, we're concentrated in these higher income, higher resource settings. And so what Carol was trying to do was just to define epidemiology of who needs thrombectomy, figure out what services are required just to get these patients, to a hospital where they might have this capability. Who's going to do these? Can we do some education and training? And then outcomes, global outcomes of a large vessel occlusion stroke with and without thrombectomy. There's many papers showing that patients who get thrombectomy do much better than those who don't. So that's not in question. So he's made 2 visits so far, and he came and gave us a grand rounds on this. One in 2023 and just recently in August of 2024. And he was really just assessing, what would be their readiness? How do we get the patients there? Who's going to do these procedures? Help training the local physicians. Again, it's not going to necessarily be neurosurgeons doing these procedures. So he's done some really good work. He brought over one of our residents and one of our medical student research fellows in the last trip. And I think he's going to bring over another group in 2025. And then one thing that's sort of a future direction is this collaboration between, I'm sure all of you know Dr. Safai, this collaboration between this institute called the MARE Institute, the Moroccan American Institute for Neuro Rehab, which is in their capital city. They specialize in neuro rehab and research. It's an outpatient facility, so it's not like the Nielsen where you're admitted there, but they're treating these patients for TBI, stroke, spinal cord injuries, hydrocephalus. They have a really long wait list, is my understanding. And we're hopefully going to set up that partnership so that some of us can go over and help, just exchange ideas. And Mo has a personal interest in TBI because I had a family member who was significantly affected. And so just to wrap it up, I think modern neurosurgery is complicated. When I think about the cases that we do here, I can take someone to an OR that has an MRI machine in it and make sure that we get, all of the tumor out. And we have, high resolution navigation that can tell us where to do a craniotomy within a millimeter of accuracy. And we have fancy endoscopes. And it's easy to forget that these things are not available worldwide in many places. So I think global neurosurgery is still a bit of a niche area in global surgery. I've talked about the biggest priorities and that there's definitely not enough neurosurgeons to meet the demand. Again, I've probably defined the problem well, but not done much to solve it. But I do know that education and training are all needed and that we need metrics to evaluate how we're doing. And that picture is blurry up there, but that's a thing called a Chopra shunt, which is a very straightforward shunt system that costs less than $100. It was developed in India, and it's actually used all over the world to treat hydrocephalus. It's a very simple design. It's not, like the low profile, programmable, MRI compatible shunts, that we have here. But it costs, I think, $70 or $80, and it can absolutely be a life-saving device. And unfortunately, there's a lot of places around the world where there's no access to this. So a lot of data on defining the problem, not a lot of data on solving it, but I'm open to any ideas. And thanks. Can't see who's on.
If someone wants to ask a question, would
They should be able to. Okay.
be heard? So Sarah, do you have any ideas regarding Africa? How many neurosurgery residencies there are?
No, I tried to look at that. I went from like Burkina Faso, which actually has one now, shockingly. But the data's all over the place. Essentially, I resorted to like Google searching, which I don't think is reliable. But there's some countries that have many. So Algeria and Egypt and Morocco and South Africa are very well set up. And then sort of all these countries in Western, Central, and, kind of Southeast Africa are extremely underserved. So, but I wouldn't be able to give you like hard numbers. So
the procedures, if somewhere had no neurosurgical care, I assume that the procedures you would suggest they start with?
yeah, probably burr holes for hematoma and hydrocephalus, either placing a drain or placing a shunt. And again, that idea of like task shifting where they say, well, less qualified providers are going to do that. I think that's not a good way to put that. Here, since Dr. Nunez is here, he does half of the shunt anyway when we're in the OR. So, and I don't think it would be difficult to train, a well-qualified general surgeon to do the other half. I think the problem is going to come. Initial shunts are very easy. Shunt revisions can actually be very complicated, so who's going to do that, is an issue. But in terms of a life-saving procedure, if there was someone there that could place a shunt or a drain, that could buy time to get the patient to a neurosurgeon, I personally am all for that. Again, some of my colleagues are really against this, that kind of scope creep idea, but I personally would be all for it.
Because what's the alternative?
Exactly. Yeah, exactly.
It's a question here too, right? Because
Yeah.
I did an acute care surgery fellowship, and that was built around the idea of ending up somewhere in rural Montana or middle of nowhere in Nevada, having a trauma surgeon who could do a burr hole. And there's a big debate on scope creep at the time. And so the entire field just shifted to, you did more fellowships, so you should be in an academic center. And that's not why it was created in the first place. But
Yeah.
there's still no one in these really rural places who are.
I would argue that you would be very qualified to put a burr hole in, if that's what it takes to just decompress an epidural to get them to a neurosurgeon.
How often do you have a sense of how often this happens in really rural places that never make it here?
Yeah, I don't know. I mean, even here in Utah, we have people who we get called about to the transfer center with a bleed that are deceased by the time they get here because of delays. Worldwide, I don't know. I only have the data on sort of the consults and the cases, but I don't know how many of those, again, there's no outcome data. That's the problem. So how many of those got care too late, passed away, or ended up, significantly, neurologically impacted? I don't know. Yeah, that's that gap, in care and metrics. So, but a lot of research opportunities with this, and I know a lot of neurosurgeons around the country that I'm trying to collaborate with. It's like herding cats to get everyone's schedules together, but there's a ton of interest in this in our field. It's so under researched. So
I assume there's a global neurosurgery committee or task force under your.
there is. It's very recent. Yeah. So, but it's generating a lot more interest, and now at least it's part of our professional societies. Like I'm sure it is for you guys too, but it wasn't until, really recently, the last decade or so.
Yeah, I see most of those papers had Key and Gale on them, and I was there in Geneva when we were lobbying for the neurotube for folic acid, and that was a phenomenal kind of advocacy project that Gale really led. So task shifting, task sharing is a really interesting thing, because we actually have many examples of here in the US. Our trauma systems wouldn't function very well if we didn't have our PAs on service right now. And I remember when we first went to Intermountain Healthcare and suggested the first time to develop a PA for the trauma system, was so much pushback, and even in the National Committee on Trauma it was a real pushback, but it's led to now we have not only a PA program, but a PA fellowship and a specific PA. And then they initially said, well, they can't do these things. I said, well, what can't they do? So, well, they can't put in a central line. I said, why not? I'll teach them. Oh, no, they can't put in a ET tube. Well, why not? We can teach them. And so they intubate, they put in tubes, they put in chest tubes. But it was a real battle early on, and continue, as things happen. Ghana doesn't want anything to do with any kind of task shifting. They're very adamant about not doing it. When you go down to Mozambique, there's big papers that are published on task shifting. We just got back from Cambodia, where our laparoscopic course, and there's not a single anesthesiologist, but they are all anesthesia nurses who have been well trained, have been doing it for 20, 30 years. Some of the best anesthesia care providers that we've worked with in a long time. And you go to Ethiopia and you have a lady who's been trained how to do fistula repair. She's not even a doctor, and yet she's trained people around the world how to do it. And so I think it is. I like your view of at least looking at it and seeing what's possible if they're trained appropriately, if they have the appropriate oversight. And that's one of the challenges I think people have, is how do you provide adequate oversight when you train them to do something that's not really in their bailiwick. So
yeah, all we have are these surveys saying that we're doing it, but there's nothing on like how the patients did, any type of standardized training on it.
So my question is, what are you, for the University of Utah here, what are the goals for neurosurgery and this global work? You've described a massive problem.
Yeah.
How does the academic institution here engage with that?
Yeah, so Dr. Budahowski's work has been well supported. The Project Stroke in Tanzania, trying to collaborate with Mo, and then mentoring, specifically, like for me, I'll mentor anyone, but specifically women that are interested, because I think we have to attract them if we're going to close this gap. So anyone that sends me an email, just looking at this Zoom, I'm happy to meet with you, male or female. But we haven't done a ton. We've only kind of started getting interested in this, like Carol and myself, another of my colleagues, Dr. Grandi, over the last maybe 5 years. So we're way behind. As a field, we're way behind. And I think here we're way behind too. I mentioned our chair went to Kuwait City to help establish a residency, but I don't know, once he set it up, that he, went back there and looked at any metrics, to see how they're doing and what their training program is. So just giant gaps. So
Time for neurosurgery to reach out to the new vice president of health sciences.
That's right. Yeah, yeah, probably has an interest in this, so.
Dr. Menacho, as the global surgery community kind of gets together and talks about, so that's the DCP3 list, for instance, and there are different forms of that, and helping countries know what to measure and how. I know that Dr. Price and I have been involved in those kinds of discussions. And you've kind of presented a core list of neurosurgical procedures that you would consider essential. Where would you stratify those? Are there tiers of that? Like, would you expect a district hospital to be able to do a burr hole?
Yeah,
What would you, as far as like, I look at bellwether procedures. I look at laparotomy, C-section, and long bone fixation. That infers a broader capacity to do surgery, but it's not necessarily the tertiary level of care, right? We're not doing Whipples and things.
yeah.
Where's that middle ground that you would put at like a secondary level hospital?
In terms of like what procedures?
What
Yeah.
basket would you put there?
Yeah, I would say from the research, that I did that emergency trauma and then hydrocephalus have to be the top two priorities. And I would argue that if there is no neurosurgeon there, that this task sharing, that I think, someone like yourself or, you who's fellowship trained, it would not be hard for you to be comfortable with those procedures. And really from an equipment standpoint, I showed you that really simple shunt. It's not this complicated thing that we're constructing in the OR here. And honestly, no offense to Jane, but you may not even need an anesthesiologist for some of the burr holes, depending on the patient's neurologic status. And also, if we have patients that are frail that we don't want to put under general anesthesia, we'll move them to the ICU and we'll do it under local, so you really don't need a lot.
As far as the hospital, so the bellwether things tell me you can do a lot more, but it doesn't cover neurosurgery at all.
Yeah,
That's just out the window. So in
Yeah.
that kind of hospital,
Yeah. I mean, I guess if you can do a craniotomy for hematoma, could you do a craniotomy for tumor at the same hospital? I would say maybe, depending on where the tumor was and whether you needed a microscope or things like that. But, you might be getting at something like, does the hospital have like an ICU to take care of them afterwards? Like things like that, that could be a problem, where they're going to go, how long do they stay there, who's paying for their hospital stay? Like in Burkina Faso, patients paid out of pocket. There's no there might be now, but there's no national insurance, so where do they go afterwards? So all that infrastructure I think would be really challenging, because as you know, our patients, like a severe TBI, can spend a month in the ICU, before going to their next destination. So I would probably start with just, the trauma and the hydrocephalus stuff and build out from there, but you wouldn't need a lot to do it. So, and I guess the question would be, would you, if you're doing the distal part of a shunt, would you be comfortable doing it without visualization, like insufflating somehow and then popping in without seeing it, if you didn't have a camera? I mean, I don't know what the answer is. So probably it depends, right? So
Fascinating looking at these, we had all sorts of debates of how many different procedures kind of would fit in that. You said the 44. We had a debate about 15 and a debate about 21. And
everybody wants their procedure.
Yes.
Yes. Even for the Lancet Commission, I remember when John Miera called, because they're trying to figure out these bellwether procedures, and the ophthalmologists were pushing to have cataract in there. And so we talked about, well, what were the bellwether procedures supposed to do? It's supposed to indicate a place that has more capability than just a little clinic. And if they have really all the bellwether procedures, they can do exploratory laparotomy, long bone fracture. Those are probably the places where you might be able to expand some neurosurgical care with at least the people that you have there. So it wasn't that neurosurgery was left out. It was trying to find what is that basic.
I guess my question is, how do you leap from the purpose of a bellwether procedures is one thing,
Yeah.
and then the purpose of the DCP3 list is another, and how can you, at that level of hospital, where's that slice of neurosurgery?
Yeah, and Charlie Monk did a nice thing just with coming up with, like you talked about, with things that are depending on what level facility you're out at, what is essential, what is, let's see, there's the different kind of what's essential and what is, can't remember the different categories that maybe you don't need this one, and this one absolutely not. Was a great thing they did with the World Health Organization, and but that'd be something could be done with neurosurgery. You know, in terms of it, as one of the projects is trying to really define that as to levels and who might be able to be trained, and then coming up the coursework and how you train it, and that'd be really cool. They had a mobile neurosurgery group that was doing throughout Kenya, at least East Africa, and places for shunts, and they're doing with the mobile.
Yeah, there's a ton of those.
Yeah, and is that still going on? Do you know anything
Yeah.
about it?
There's dozens of them that go on. And again,
The follow-up, if you know what I mean?
right, that's the problem.
Yeah.
Yeah. I think there's just such little data on that. You know, placing a first-time shunt, I think, is pretty straightforward. But if they get infected or it clogs, you know, that can get difficult. And who's doing that? I can't find much on that, you know. There's some like maybe single center stuff where they look at 10% got infected and needed to come out, but then they don't talk about how the patients did, you know, anything like that. So.
Do you work with Key at all? Key Park? He was on your papers, a lot of your papers there. So Key Park is a neurosurgeon. He's based out of Harvard now, but he was in Cambodia for 8 years or so. But he's working advocacy wise at the World Health Assembly and things as well. But we ought to get you in contact with Key and
Oh,
Gail
I
as
love
well.
that. Yeah, there's a lot of interest amongst like sort of the, not that I'm that young anymore, but the younger neurosurgeons in our department, you know, to get involved in this. So not just, you know, Carol and myself, but a lot of us. So.
Fantastic.
Thank you guys.
Great.